Welcome to another installment of our ongoing series, Leadership and Trust in this age of uncertainty, given this ongoing pandemic. My name is Michael DeWilde. I direct the Koeze Business Ethics Initiative here at the Seaman College of Business, Grand Valley State University. Very pleased today to be joined by two palliative care physicians who also do other things as well, Dr. Jason Beckrow and Dr. John Mulder. Both involved in palliative care for a number of years, and in fact, Dr. Mulder, one of the pioneers of that palliative care. Gentlemen, if you don't mind, to get started, and maybe John, you can take this first, since we're going to be dealing with some different terms along the way: hospice, end-of-life care, palliative care, etc. Do you mind just laying out some of the relevant distinctions between those, so we have those touchstones?
Sure. Palliative care, it is a relatively recent medical specialty, probably about 30 years in the making, officially just for the last 14 years. But we, as a practice of medicine, are poised to relieve the burden of suffering and to improve the quality of life for folks that have things that we can't fix. So advanced illness, serious illness, things of that sort. Not, maybe terminal, maybe not. So it really is intended on focusing on patients' values, what's important to them, and how we can best relieve suffering and to allow them to live as well as possible. It grew out of the hospice movement, and because of that, we often are sometimes confused with hospice. And while a hospice deals with imminently end-of-life issues and provides a team to help to provide comfort and care for those that are in the last months of life, palliative care has a very, very long reach, and we can provide care for people that may not have are not imminently terminal, may not even have a terminal diagnosis, but have a burden of suffering that accompanies their journey.
Great, that's helpful. Thank you, Dr. Becker. Anything you want to add to that? And if you do, or if you want to move on to the next, maybe you can talk a little bit specifically about your role. So what's a day look like for you, and what are some of the issues that you deal with?
Sure. So I'm trained both as a medical oncologist and as a hospice and palliative medicine specialist. So I actually do spend more time wearing my hospice hat with end of life. And the word I use oftentimes is a bridge. It's kind of a bridge between what we consider acute care. I'll meet a patient on day one with a new cancer diagnosis where everything is focused on the treatment of the cancer itself. Palliative medicine is that bridge to try to make the best of, John used the term relieve suffering, both the suffering of the disease itself as well as the treatments related to that. And then as transition, if the disease gets to the point to where, especially when the treatments become worse than the disease itself, we then transition into hospice care. So the goal is to create smoother transitions to maximize one's quality of life, to have a meaningful life for as long as that may be.
Sure, thanks. And John, you said palliative care is relatively recent. How does it fit, or how is it seen by the rest of the medical establishment?
Well, I'll talk specifically about Grand Rapids because it's a really diverse level of integration and acceptance across the country. Grand Rapids is a little more progressive than many other areas of the country. In fact, a couple of years ago, we were in a survey rated as the number one place in America to die, and that was a good thing. What they were saying is that we knew how to take care of people that had advanced illness, and part of that is because of how we have worked to integrate palliative care as the norm within our healthcare system, that it would be available just as readily and as easily as any other medical subspecialty. So that, if you've got a heart issue, you might see a cardiologist. If you have a skin issue, you might see a dermatologist. If you have an issue with challenges with a serious disease, then your physician may indeed have you see a palliative doc. And so what we're seeing is that some of the stigma that was attached to that. For example, I had once a physician came up to me and said to me, "Boy, I've got someone I'd like to send you, but I'm not sure that they're ready yet." And I thought, Well, what does that mean? We're there to relieve the burden of suffering. Tell me when someone is not ready for that. but his issue was that he still saw it as directly related to imminent end of life. And so I think that we've done a very good job in Grand Rapids in terms of teasing that apart, so that if any hospital that you might attend to here in Grand Rapids will have a palliative service available to you to help to provide that level of concordant care, so that you may be pursuing aggressive curative therapy, but have significant symptom issues. We can address those, because that's one of the two things that we really do. Our two main goals are, number one, to address problematic symptoms, and number two, to help strategically plan what lies ahead given your current circumstance. And so we're seeing much greater level of acceptance by the medical and with the lay community here in Grand Rapids for that.
That's a big change, I assume, from 10 years ago, 15 years ago. Dr. Beckrow, you would not have seen that same willingness or acceptance?
Absolutely. During my training, it was much more rare. Things would happen, especially, something on a Friday afternoon, we'll have to wait till Monday morning. Now, knowing that you have services 24 hours a day, 7 days a week, nights and holidays. In the 20 years I've been practicing, it's been great and very gratifying to see that much more robust services provided, much more diffuse. And people like John, as you said, I think you used the term pioneer. I probably wouldn't be here on this call right now if it weren't for John, and people have been awesome mentors to me and my colleagues.
Yeah, thanks.
Mike, just emphasize that when I moved back to Grand Rapids in 2006, there was one other palliative doc in Grand Rapids, over at St. Mary's, and we a few years later, about 10 years ago, we developed a coalition, a kind of a very loose network of local and regional palliative docs, those who are working in our field, and we continue to grow, and we have over 80 docs on our list right now. And that region stretches from Jason down in St. Joe to Lansing and over to Muskegon. And so that quadrant, we have over 80 palliative physicians. And you consider what we had, 14 years ago and where we've grown. I think that also emphasizes the how we have really established ourselves here in West Michigan. Great,
thanks. And I probably shouldn't put it this way, but from your perspective, has the pandemic in any way, shape, or form been something of a silver lining in changing the nature of the conversation around death and dying, or helping facilitate some forward thinking about one's mortality? What are you seeing in terms of the impact of the pandemic on people's preparation for, willingness to have a conversation about it?
Well, I'll give you a real quick viewpoint from my perspective, and Jason's a little bit closer to the bedside than I am. But my observation is that not so much a silver lining, but we've had a chance to establish what we do. And there, several of the aspects of the COVID pandemic, while yes, people have been coming in and we have been looking at a greater need for having goals of care conversation with people that are terminally ill, it wasn't necessarily just the COVID patients that this has impacted. What we found is that hospitals have had to make some changes in how they view bed utilization strategy. And so they're asking palliative docs to help work with other patients in the hospital to look at dispositions and discharge planning and goals of care to really kind of ramp up the ability to the throughput through hospitals to get people out of hospital beds that didn't need to be in hospital beds, might do better somewhere else. And because palliative practitioners are very, very good at those types of goals of care conversation, and both environmental planning and strategic planning, we were called on for that. And again, the advanced care planning thing, which is a core part of what we do, became very, very critical as people began reflecting on, wow, how is this going to affect me? So it's not that, yes, we had so many COVID patients coming that we had to take care of COVID patients. It was that the system was re-examining how they're treating all of their patients, especially those in the intensive care unit, because we wanted to make sure that if we had scarce resources, that to allocate on a stringent basis how we're going to best make decisions about who really needs that and who's going to benefit from that. And palliative practitioners can help with those conversations.
I have found, very similar to what John just alluded to, and you were asking about silver linings, or and I try to be optimistic, but I don't want to be cavalier either. But in a way, when any individual deals with serious illness or terminal illness, a cancer diagnosis, sometimes that's can be a very lonely situation. The COVID pandemic has kind of forced society to deal, maybe not with the immediate health impact to each individual, but most of us, watch any news outlet and you're seeing this happening to friends, neighbors, family members. So a far more global facing of our reality of our impending mortality. And I think then the silver lining can be a greater sense of empathy, what people are going through.
And you're seeing that in frontline workers, in families. How's that showing up?
Hospice and palliative medicine workers spend a lot of time, importantly, and with self-care. And, when we start an interdisciplinary group team meeting, our reflection time, sometimes that got kind of thin and maybe pushed to the side, and a lot more time is being spent on reflecting, caring for ourselves so we can care for our patients and families, recognizing that that's being stretched thin professionally and personally for everybody. And again, when that's working well, you see great empathy. Sometimes that does get stretched a little thin.
John, would it be fair to say that it's empathetic to revisit the question of futile care? You and I have had conversations in the past where, because of tradition, habit, family pressure, whatever it might be, there's an extension of care beyond, at least sometimes in your opinion, what's called for. You were talking about allocation of scarce resources. Are you seeing a kind of either individual or systematic change around that conversation that maybe we overtreat?
Yeah, I don't think there's any question about what we overtreat in America. That's been verified and validated by a number of studies in terms of the numbers of Medicare dollars that are spent in the last several weeks of life, and in many circumstances that has no impact on outcome. In fact, some of the interventions we do might hasten someone's death while increasing cost and increasing the burden of suffering. And so, doing the right thing for folks is really critical, and what we in Palliative strive to do to make sure that everyone's getting exactly the right care that they need. Again, consistent with their values and what's important and sacred to them. And so, what we're finding is that we live in a country of medical excess, right? We have abundant resources that we have available, and therefore the tendency is to just throw a lot of this stuff at people, and the default is to go ahead and put them in the ICU, go ahead, put them on a ventilator, go ahead and give them all of these different things, and that can even even at the level of cancer care that Jason can most intimately relate to, where people have a cancer, and I just got a note just about an hour ago from someone who was lamenting about her husband's experience with cancer a few years ago, in which the physician was sort of insisting that they do brain surgery on this person that had a metastatic cancer. And the wife with medical background said, "Well, why would we do that?" And he said, "Because that's all I have to offer." Okay. Well, so it's all the proverbial. Well, if if a hammer, everything looks like a nail. That's what I do for a living, is take out cancers. It doesn't matter what the patient wants, what the outcome is going to be. That's what I do. And so in America, we've had a tendency to do that. We provide more and more care because we have it available, and because we can, and because we have payment mechanisms that will pay for that. So what's happened in the course of the pandemic is it really has forced these conversations to really, what is the value of this? And I remember talking with a couple of ethicists on the other side of the state here, in April when this was really at a crisis area in the Detroit area. And they were commenting that they were now having conversations with people, at the beginning of their hospitalization, at the beginning of their ICU stays, as to what their goals were and whether this was really an appropriate thing to do. And my flippant, somewhat cynical comment was, "Oh, so you're doing now what you should have been doing all along."
I'm sure they were happy for that feedback.
Yeah, I didn't get a lot of chuckles out of that as I expected I might. So.
It makes me want to ask, Jason, let me switch it back to you. As the saying goes, you never know what might happen, right? You go in, you feel healthy, or, I'm going into class later today, and, it's who knows what happens to me in a week or two. I get the sense, I'm listening to both of you, that I could probably educate myself much more than I have about ways to advocate for myself, about conversations that I might have as I'm getting up there in years. What's your best advice, or how do you counsel people like me who are, getting on the other side of middle age and are exposed to certain risks?
Well, there are both existential answers to that and then practical ones. Existentially, again, societally, we don't like to think about our mortality, about dying, right? I mean, we're relatively young and healthy today, and that only happens to old people, right? So we like
I'm
to
asking
avoid
for other people, basically.
You got it. But then there's, the practical part of it as well. And so the practical answer there is using advanced care planning. And that can be as simple from, declaring what your wishes are at various stages of life. Again, someone with a serious illness or a terminal illness is thinking about that in a different term than maybe someone who's relatively healthy. But people get into car accidents. The pandemic has forced us. We've seen relatively healthy people get sick and die. And so the con being, as a society, we avoid talking about death and dying. The pro is we're very autonomous, and we very much respect our autonomy. And one way that we can maximize that is, again, through advanced care planning. And so through estate planning, what we're doing in our office now is anyone who comes onto our hospice or palliative service, we ask them very specific questions for the patient, but then are able to work that into conversations with their family members, their caregivers, and there's various gradations of those conversations, from first steps, things that you or I, as relatively healthy folks, should be thinking about. What if these unlikely scenarios occur? What would we want to have happen? Second steps, I've been diagnosed and now I'm thinking in terms of, where might I be in the next 10, 20 years? And then last steps, someone with a true terminal diagnosis. There are tools and there are organizations in our that we work with that we're trying to maximize. And the more we do that, the more you will be able to make your own choices. And in addition to that, spare your loved ones the burdens of trying to guess. I think that's one of the hardest things, is when a loved one is making a decision and they're pretty sure they know that this is what dad or grandpa or grandma would have wanted, but they're just not sure. And that's something the loved one will take with them. I think oftentimes of my grandmother who, my grandfather died from complications of COPD when he was in his 80s. And my grandmother lived 5 years after that, assumed she killed grandpa. No, it was the cigarettes he smoked every day since he was probably before a teenager. But because she had to sign a document before he did, she carried that with her. And that's something I vowed a long time ago. If I could help spare folks from that, I'd like to do that. And so advanced care planning is a great way to do that practically.
Great. Thank you. John, did you want to add anything to that?
No, I agree with the, kind of spare people from that. I think that we do people a disservice when we're sitting there in the, in an ICU and tell a family member, well, should we pull the plug or not? I mean, we don't do it that blatantly, but we put the burden on them to sort of make a decision. And that's why You see people living with the guilt that I killed mom, I killed dad, I killed my husband because I told the doctor that we had to stop that treatment. And I think that a much more practical and humane approach is to say, how would your loved one want to spend the last moments of his life? What would be meaningful to him? Again, it gets back to a values orientation, right? What's important to them and how would they see this? And then I can say very confidently, well, based on what you're telling me, our recommendation is going to be that we discontinue this because it's not consistent with what he would have wanted. It's adding to his burden of suffering, and he's not going to recover from this. So we take on that mantle of saying, we're going to do this because it's the right thing to do. It's a much better thing than saying, well, what do you want to do? You want to pull the plug or not? Yeah. And so a lot of it is how you communicate these things. But again, it gets back to the issue of how do we really look at a values-based orientation to care? And that's how we start getting some more productive solutions.
Kind of an anecdote along that, John. When we turn and say, what do you want us to do? Or a lot of times people will ask you maybe things that are related to prognosis. And the one I can't stand is when a doctor says, well, I don't have a crystal ball.
Yeah.
And so I've gotten into the habit, students that I'm really close with, and I have a cousin who is practicing now in Ohio on his graduation. I did, in fact, get him a crystal ball just so he can't make that statement. We do have medical knowledge. We can't necessarily give you a pinpoint within the next 10 minutes, but we can give you some ballpark information. And based on that information and your loved one's values, and again, those values fluctuate over time, right? The values of a 20-year-old, a 40-year-old, a 95-year-old, same person at different times will vary. And we can help folks understand what are their values, what are the realities, and then make the choice. They are allowed to make the choice. It's right for them at that time based on their values.
Terrific. Well, let me segue then in the context of autonomy, values, and a term that I used in the title, you were gracious enough to go along with, and that is the use of psychedelics. So, as you know, coming out of Johns Hopkins, NYU, the Imperial College in London, lots of places, a lot of promising research picking up again from the 60s and 70s on the use of psychedelics, especially psilocybin. As you think about the alleviation of suffering, as you think about the growing body of literature on the reintroduction of these, are you hearing more requests from patients, or at least people asking for more information about the use of those to alleviate anxiety, depression, or other symptoms that are associated with end-of-life care? And if you want to talk a little bit about your own takes on each one of those, John, let's start with you.
Sure. Yeah. So I just want to say, first of all, to answer the question, are we seeing requests? Yes, not abundantly, but I think that there's a different approach to this. Patients don't always know what to ask for. They know what's troubling them. And our job is to make sure that we've got a great, quiver of arrows that we can shoot at what's ailing them. And so, if we look at kind of at the advent of the contemporary hospice movement, which is, somewhere in the neighborhood of, 40 some years old, starting in Britain, they developed what's called a Brompton's cocktail. Brompton's cocktail has as its key component heroin, and heroin is an opioid. It's diacetyl morphine, I think, is the actual technical name of it. And so it's in the same family. It's an opioid, relieves pain, relieves suffering, and so it was used that way. We even see the evolution of opioids within the United States and other Western countries that began. Somewhere in the 70s and really escalated to the 80s and especially into the 90s, that in some manner, has resulted in some challenges with how we're managing opioids here in the United States. But the point is that the genesis of that was that people were suffering, and they needed options and alternatives to relieve that suffering, and opioids turned out to be a really great opportunity for that. Yes, some people took it to an extreme and took it to non-terminal and non-malignant pain issues, but nevertheless, it's been a great asset to us. We now see the kind of the burgeoning of the marijuana industry. And while most of that tends to relate to recreational use, the kind of the foot in the door for that was to approve it for medicinal use and for medical use. And while there's a lot of kind of wink sort of things on medical marijuana, people who really were claiming medical issues so they could get it to use it recreationally, the fact is that there's a very rational basis for how marijuana might be useful. And what types of symptoms it might mitigate, and so there's a very rational basis, and gradually the medical care system is catching up. Legislatively, we still have a little ways to go, but there's some value to that in very certain circumstances, and in the same manner, psilocybin has a very similar thing. It's been very remarkable to see how that has eased a number of different issues of suffering at the end of life, especially with a lot of existential suffering, a lot of depression, anxiety, agitation, is very, very effectively treated with psilocybin. So does it have a role? Yeah, and I think that these studies are very, very encouraging. Again, another medication that is sort of in the category is ketamine. Ketamine began in a when it was studied alongside things like psilocybin and LSD back in the 60s for its use as hallucinogenic agents, and ketamine found a different role, but it still is very, very effective to relieve a lot of end-of-life symptoms, including depression and pain and things of that sort. And so that's one that we have a lot more legal latitude to use in a very productive way. So yeah, I mean that's a long answer to the question, but I think there's great value in these medications. I think there's still much to be learned about it, and then alongside the studies, we need to be working on some opportunities to have it legally available to us in certain circumstances for certain subsets of patients who might truly benefit from that.
Is your professional organization, and I'm sorry, I don't know what the palliative care physician organization professionally it's called, you'll tell me, is that something that they are currently lobbying for or considering lobbying for?
So I would tell you that the organization is the American Academy of Hospice and Palliative Physicians.
Thank you.
AAPM. We just refer to it as the Academy, and those of us in the field understand what we're talking about when we talk about the Academy. So they are not actively, that's not part of their legislative agenda. However, at every conference we've had over the last 3 or 4 years, there have been presentations on use of psychedelics. And they have been very, very well attended. And there's a lot of enthusiasm among the rank and file to say, this is something we need to take a closer look at. This is something we need to have in our armamentarium to be able to use. So I think that when we see the opportunities, we will see a number of physicians who will be willing to be on the front line of prescribing that for their patients.
Dr. Beckrow, did you want to add to that before I?
Just that, again, there's a lot to be learned. It's one of those areas where you need to balance the risk of abuse with then the benefits, and in this case, we're talking about the relief of suffering. So it is great to see the research that's being done and the growth. My guess, if we have the same talk 5-10 years from now, we'll be able to talk a lot more. 5-10 years ago, we probably wouldn't have talked at all. So progress sometimes can move at glacial speed, but it is progressing.
John, let me pick up on something you said. I appreciate your the depth of your answer, and that is, I think of Michael Pollan's book, How to Change Your Mind. It's probably the best and most complete book recently published on the use of psychedelics for a number of reasons, medical as well as spiritual and psychological. In there, he talks about the importance of setting and intention, and even having a guide, somebody who's really well prepared to help with whatever comes up while you're under the influence of one of these drugs, specifically psilocybin. He also talks about LSD. is that something that you think probably gives your profession pause? And that is, there may not be a lot of you who are as prepared as they might want to be to deal with whatever the effects of somebody's inner journey might be?
Well, I think that is going to be an issue. I mean, I would tell you that any practicing physician, it's a whole lot easier for them to spend a few moments discussing risk benefits of medications, what they hope they'll be able to accomplish, write the script, and move on to the next patient. The prospect of spending several hours with a patient might be, professionally rewarding. It doesn't reimburse very well, and the issue of having, if that's how you're going to focus your practice, then that's fine. But you have to get used to the fact that if you're only going to see a couple patients a day for psychedelic use, I personally think that what's going to happen is that a lot of those protocols are done out of an abundance of caution, because there is uncertainty on how any individual is going to act in response to the medication. I really have a sense that as we do more research, we're going to find that as we sophisticate our approach to extracts, doses, concentrations, administration protocols, we're going to probably see a more standardized approach to that that's not going to require such monitoring. And there are other drugs that we've had very similar sorts of caution at the onset. And once we got more comfortable, I wouldn't say cavalier, but we just got more comfortable understanding how these are going to work, it allowed us to loosen the reins a little bit. I think the problem when we're talking about psychedelics, and this is always a challenge, is that when someone is having an experience with that, are we really truly, let me say this a different way. Are they able to experience what is truly in their mind, their heart, and put them at ease? Or is this just a smokescreen that somehow it's creating a false narrative that that is either pleasant, usually it is, or somehow negative? Does it have the potential of uncovering more repressed and suppressed emotions and senses that could be disturbing and problematic for the patient? That's where you really need good psychological assistance with this. So there's a lot we don't know about it, but yeah, we as physicians, do I as a palliative physician welcome it? Yes, I do. Do I feel comfortable understanding exactly how and when we're going to use that? Not yet.
Can I ask you maybe to answer your own question in terms of the use of ketamine? Have you seen those same concerns in terms of, you called it an authentic, sort of insight into one's mind and heart, as opposed to perhaps a smokescreen that's a false narrative in some way? With ketamine, have you formed a conclusion about that one way or the other?
Oh yeah. So the two places I use ketamine most commonly are for pain and for depression. And our use of ketamine for depression in end-of-life population is fairly well regimented. We've had about 10 years of experience doing that. We know the doses to use, we know what to expect, and we can really help the patients understand that. We don't use doses that produce a psychedelic effect. We don't use doses that produce what we call psychomimetic effects, or hallucinations, bad dreams, and things like that, which higher dose ketamine can absolutely do. But that doesn't happen in our realm. It's interesting that as we become more comfortable with that over the last 5 to 6 years, we've seen evolve ketamine clinics. And I suspect that you can just Google ketamine clinic, and there's going to be one near you, in a neighborhood near you. And they will have you come in for an IV infusion and have you stay there while they do the infusion. So not too dissimilar to what you were talking about with the psychedelic treatments. It's a shorter interval. And they do that every few weeks, but it's very, very effective in terms of treating that. And again, they do that in that particular context. The dose is a little bit higher, and being that it's being infused intravenously, they want to monitor for any effects and side effects and negative consequences before they let someone go from there. So that's a similar model. Of course, that's absolutely legal and absolutely appropriate, and it works well.
Okay, thanks. Jason, I'll come back to you, but the question is for both of you too. And so maybe parallel is the wrong way to put it, but there's another movement besides the movement to legalize, or at least make available to people who do what you do, psychedelics, and that is the assisted suicide question, that issue, which kind of waxes and wanes in terms of public debate. As you know, the Netherlands is conducting a long-term experiment with that. There are a couple of states that allow for it under certain conditions. Again, I'll start by putting the question this way, and that given the pandemic, and again, given the risks that it poses to so many in your practice, are you hearing that conversation again, where people are wondering about the possibility of assisted suicide, and can you speak to that?
I can speak to that. And before the pandemic and after the pandemic, that'll always kind of be there, right? And it comes back again to the relief of suffering in both physical and non-physical forms. When I was in medical school back in the 90s, that's when the topic was very much in the media, before it was legalized in other parts of the country, with Dr. Kevorkian here in Michigan. And when suffering is poorly managed, it makes it very understandable why, again, trying to tease out when does depression or other mental illness affect judgment, when it's sound judgment, who decides that. But again, it's kind of when I'm with a patient, and they usually won't ask you specifically, can you help either euthanize or help my loved one end it, but they'll ask you a question that's, there's kind of the surface question, or is there a bigger dose, or sometimes a meta message being asked. And I have found that when you address that directly, and we focus specifically on the relief of one's suffering, recognizing that at times there are worse things in this world than dying. Dying a very painful, emotionally, there are things that are far worse. So when we address that, then usually it's satisfying to patient and loved ones. But when we fail to do that, it makes the I think it's the individual that feels that their suffering is being unmet, and there's nothing in society, from doctors or from the healthcare establishment, etc., that will help, that they want to have the autonomy to take that next step. Thank goodness, as we talked about with the expansion of hospice and palliative medicine, advanced care planning, we are addressing that more. And with that, the direct request for physician-assisted suicide in my practice has gone down significantly. Again, it's never zero, and there's other things to consider, but focusing again on the relief of suffering in whatever form, physical, emotional, spiritual, existential, that usually helps things out a lot. John, you've had this experience yourself.
Of course, yeah. I mean, I was just a disclaimer. I'm against the practice. I don't think that that's a role that physicians should fill, is hastening death. I think it's tragic that anyone should wish for death because of the fear of suffering. And I would say the vast majority of requests, when you look at Oregon, for example, who has the longest experience of that now, 20 some years, I think, of this practice, the vast majority are these folks don't have suffering. They have a diagnosis that portends a poor prognosis. And they're afraid that when they get to that point, that they may lose control, or they may be suffering intractably, and they want that option available to them. And so the state has allowed them to get a lethal prescription to allow them to do that when the time comes. But as Jason said, I think that the key is making sure that we have appropriate remedies so that we can tell someone very confidently, suffering is not going to be part of your journey. And that may be existential, and it may be physical, but I can tell you that we've got some great strategies, and it always when I hear of these cases where someone has ended their life prematurely because of the fear of suffering, I just always, just for a moment, wonder what type of joy did they miss out on? What type of relationships did they sacrifice because of their fear of suffering? Jason, this is never going to go away. This is something that is it's pandemic irrelevant, and even if we had a national referendum that allowed this, the conversation is still going to go on. In terms of how do we best approach that? People come, well, we treat our dogs better. They shoot horses, don't they? That sort of conversation is always part of it, and that's not relevant to our conversation.
John, I take your point. Let me ask you this, since it's growing in number of incidences, maybe not for you, but for other palliative care physicians, would advanced dementia or Alzheimer's be an exception to that principle based on the lack of remedy or effective remedies?
Well, effective remedies for what, Michael? I mean, I can show you Alzheimer's patients who are experiencing much joy and are giving much joy to their families. I will tell you that much of the suffering that relates to someone with advanced dementia, the suffering is in the family. The suffering is not in the patient. I remember one of my very first requests for assisted suicide was a grandson who was just beleaguered and weary from sitting at the bedside of his grandmother, who was not conscious, perfectly peaceful. And he said to me, "Can't we do something to put her out of her misery?" And I commented, it says, "She's perfectly comfortable. Let's talk about putting you out of your misery." But the point is that and that when I think my mother is 95 and has dementia, and would I entertain an opportunity to try to shorten her life because she's confused and sometimes doesn't remember names? And no, she is, the people in the facility they derive great joy from caring for her. She gets a smile on her face, just from people coming in and saying hi. There's a lot of joy that surrounds that life. And so far be it from me as a physician to say, you know what, yeah, she's going to die from this, so let's just get it over with quicker. No, it makes no sense to me.
Okay. So the follow-up question comes from, I'll get this in quickly and turn the floor over to you. Maybe a follow-up question comes from somebody who's listening, and that is, so when I'm doing my advanced care planning, who or what kind of qualities or characteristics should I look for in that person to help me think through that? Dr. Beckrow.
Yeah, that's a great question. Ideally you want someone, well, I guess it starts with trust, right? So oftentimes that's family members, or maybe not, depending on the situation. Someone that you're comfortable having important talks with on a somewhat repetitive basis. Again, as time evolves and people evolve, choices may evolve. Someone that you trust to then execute the decisions that have been made, especially if they may be difficult. So, what I've done personally is I've talked very openly with my spouse, and then with my kids. My kids I have a 16 and 19-year-old now, so one's legally an adult and the other one is practically an adult, and so they're a huge part of our understanding. Sometimes they may not be family members, but I guess the key there is someone that you trust, someone that you can talk about those difficult things with. And then reaching out to an organization like John and I both work for organizations where we have trained facilitators who can help start the process in whatever form is most comfortable for the person.
Thank you.
Yeah, if I could just supplement that, trust is important, and I look at when I talk to people about who to pick, it's someone who understands you, and someone who's going to be able to parrot your values, and I think most important, someone who's going to be rational. You don't want decisions being made emotionally in the spur of a moment. They need to be so someone who's going to be able to take a deep breath and speak on behalf of you, and not impose their own will and their own judgment.
Thanks. Maybe we can close with this question. It comes from a student who's listening, and we'll go back to the pandemics specifically. Top of mind is as campuses become hotspots, and as two physicians who work with diseases of all kinds, and both terminal and non-terminal, you want to weigh in with an informed judgment on when you think institutions should look carefully at going back to a more, or let's say a safer, less physically intense environment? This comes from a student. It says, at what point does, for example, a campus shutdown or other institutions you could substitute be considered?
John, if you like, I'll go first, and I'll wear another hat I wear is I'm president of a school board down here in Southwest Michigan, and the question's a great one because you're trying to maximize public health and public safety with individual well-being and individual rights, and I think it's quite clear that there is no one-size-fits-all answer, or no answer that probably we can all agree on. So my answer will probably be very dissatisfying to a large number, and maybe sometimes that's the idea. We've relied a lot on our county health departments. We've tried to weigh, the number there in the comment says 500. Michael, can you tell me, is that the number of cases at Grand Valley? Is that total? Is that per capita?
I cannot confirm or disconfirm that.
Okay. Again, I don't know what that number, if that refers to total number of cases. Then you have to look at density. You have students, I'm assuming it's Grand Valley still, where students are in dorms and going to online and in-person classes, some type of hybrid.
Yes.
Okay. I can't give you a number to that, but I can tell you what goes into the equation. It's trying to balance, again, the public safety, the risk of spread, versus the individual's well-being. So in a public school, and John can relate to this too, his wife is a teacher, we very much want to protect our students and teachers, but what's happening to children if they're not getting into the school environment? So again, I can't give you a number. I can only give you the criteria we look at. At present, the rates are relatively, it should be in all caps. Relatively per capita is down where we were in March and April, but that's likely to strike again. And so we've taken the approach of let's take advantage of the opportunity we have to get our students together to advance their learning, to prepare for where we may be weeks down the road. And then we've relied very heavily on our county health department and public health.
Thanks. This has been a vexing one for everybody. I do appreciate that.
Yeah.
John, get the last word, and then we'll need to close out.
Well, yeah. I mean, this started out as talking about pandemics, and so I guess it should close on that as well. This is a frustrating time, without question. And as Jason commented, it's a matter of balancing, personal autonomy with public. And those are exactly the ethical questions that those of us that work in ethics also have been asking and discussing all along. What's best for the community versus what's best for an individual. In my mind, there is no question, but what you have to put aside personal preference for community well-being. I mean, that's the only way that you're going to survive this and to get over that. The communities and states and countries that have done the best are those that did almost a dictatorial, shutdown, shutting schools, shutting businesses, isolating people, testing everybody, isolating those even more that are tested, quarantine, and it's gone within a relatively short period of time. Okay, we're in the name of personal autonomy and small business owners, all these things which are hugely important, and I understand that. But we've been really fuzzy about that, and we've gone back and forth. And we'll open this, but you can only have this many people in, or you can sit on the table, but you can't sit at the bar, and all these. We're very fuzzy about what it is in terms of how we're going to relax it, trying to appease everybody. Well, as Jason said, not everybody's going to be happy. You can't appease everybody, and so when you start seeing spikes, if Grand Valley is somewhere in the neighborhood of 500, which is what I think the Wood TV reported, it's going to be more. I can guarantee it's going to be more because as Jason said, my wife works in the public school system. She's a teacher, and she'll tell you, 8-year-olds don't social distance. Okay. And so if you're going to allow people to be together, you have to accept the reality that this disease is not going to until such times we have a vaccine, and this is a huge and that people are willing to take the vaccine. Right. Otherwise, you're going to see this thing smoldering and smoldering for a long, long time to come. I hope that's not the case, but that's how viruses work.
No, I appreciate your insights and the time you took today. This conversation could go on. I would like it to go on, but I want to respect everybody's time. Thank you so much for taking the hour and sharing your wisdom and knowledge with us. I really appreciate it.
Enjoy the time. Thank you, Michael.
Okay.
Thank you.
We're going to talk again soon. Thanks.